Good morning, everyone. Really excited to have everybody in the room today. Welcome to the BC PSR Advanced Practice webinar session for July. We're incredibly pleased to be offering you our midsummer session. Not something that we usually do, but from the response that we've got from the community, it's definitely something that we want to be doing. So today's session, if you're here for, just to confirm, psychosocial interventions for psychosis, cognitive remediation, and metacognitive training with Dr. Mahesh Menon. And just to remind folks that today's session is being recorded, but all your names will be anonymized, so they won't appear on the recording. A reminder of who it is behind the team. This is the advanced practice as it stands today. Jordan Clark is our IT and technology support. My name is Matthew Lang. I'm the coordinator for the AP. Dr. John Higginbottom is the founder of not only of the AP, but also of all the psychosocial rehab programs at Douglas College, including their post-degree graduate diploma. And Dr. Regina Casey, who is the coordinator of the post-degree diploma program and as well the project manager for the advanced practice. A reminder for those who have been here with us before and for those who are just joining us today for our first session. This is in fact our 31st webinar of our offering over the range of our life so far, our few years that we've been in practice. But if you've never joined us, we're really happy to have you here. The BC Advanced Practice is funded by the Ministry of Health and provides leadership, education, and guidance to the mental health field in order to help develop and put effective, evidence-based psychosocial rehab practices into place. So we always want to say thank you to those who come and offer their expertise at no cost in terms of sharing what they know with our broad community of practice and with us. So, as I mentioned, this is our 31st. Thank you very much, Susan. Happy 31, that's right. If you're interested in learning more, all our sessions, as I mentioned, are recorded and available for review on the website with accompanying supportive materials. So take a check out that. What do we do with the advanced practice? Well, we are here to support clinicians and managers responsible for providing PSR services by transferring evidence-based knowledge, providing expert clinical consultation, training and education events, developing website resources, and supporting the Provincial Advisory Committee and the broader BC PSR community of practice. Just a quick note that if you've done this before, you would have known that you receive an email afterwards the session taking place with a request to complete an evaluation survey. We're going to do the same thing today. It really makes a huge difference hearing from you in terms of what worked well, what you would like to see more, and with respect to the sessions that you want to develop in terms of future webinars. So thanks very much for doing that, and thank you for continuing to do so. Moving on to today's session, it's my very great pleasure to introduce Dr. Mahesh Menon, who did his PhD in psychology at the University of Cambridge in the UK. Following that, he completed a fellowship at the Centre for Addiction and Mental Health in Toronto, where he was on faculty at the University of Toronto before moving to Vancouver. Woohoo, we're very lucky. His research program is focused on cognitive and neural processes associated with delusions, and his clinical interests are in psychotherapy for psychosis and severe mental illness. Mahesh works as a psychologist with the BC Psychosis program and the Mood Disorders Inpatient Unit at the hospital, and is a clinical associate professor in the Department of Psychiatry at UBC. He has published over 40 peer-reviewed papers and book chapters, and his research has been funded by CIHR, NARSAD, the Mind Foundation, and the Ontario Mental Health Foundation. So, without further ado, I'm going to hand the session over to Dr. Menon, and we will begin.
Okay, so welcome everyone. The talk today is, there are a number of different psychosocial interventions for psychosis. Obviously, this one is more focused on two particular interventions, which are cognitive remediation and metacognitive training that I'll get to. So, just this one?
Yeah.
Okay.
One time.
Okay. So when we think about schizophrenia itself, there is data suggesting that there are a number of changes that are happening at the level of the genes, which we assume lead to changes in terms of brain basic foundations of the brain, sort of proteins and lipids, which in turn could have effects on neurotransmitters and neuroreceptors, leading slightly upstream to dysfunctional neural networks, which then kind of lead to problems at the level of cognition and then at the level of the symptomatology that we see. Now, when we think about schizophrenia itself, we can think about it in one of two ways. We can think about the diagnosis of schizophrenia as a whole and try to sort of understand what are some of the difficulties associated with that. Or we can think about what are the processes which are associated with the symptoms itself that we see. Now, the diagnosis is what we would consider a trait level. So it is stable over the course of, once there is a diagnosis that's present, but the symptoms themselves are state-based, so they sort of wax and wane and change over time. So when we are looking at studying them, what we want to do is sort of go the other way, where we want to sort of begin with saying what are the challenges which are associated with schizophrenia as a whole. And one of the things that we know is that they have poorer functional outcomes, and to look to see what are the levels of specific factors associated with that at the level of cognition, and then work our way further downstream from there. So when we think about what are the deficits which are associated with schizophrenia as a whole, and what are the cognitive deficits which are associated with functional, what are the cognitive deficits which are associated with these poor functioning. What we know is that deficits in cognitive functioning are very reliable, not just in schizophrenia, but across the schizophrenia spectrum disorders. And that the magnitude of these cognitive deficits doesn't necessarily correlate with the severity of delusions or hallucinations that the person is experiencing. But importantly, the magnitude of the cognitive deficits that are present are a very reliable predictor of daily life functioning across a number of different domains. So these are data from Chris Bowie, and this is essentially sort of statistical modeling of functioning. And what they did was essentially look at the impact of different domains of cognition, as well as positive symptoms, negative symptoms, and depression on daily life outcome. And these structural equation models essentially will show what are the paths which are significant. Now, the take-home message from this one is that you'll see that essentially different domains of cognition either directly or indirectly have an effect on interpersonal behavior, community functioning, as well as work skills. And what you'll notice is that the cognitive domains that we see, so I'm going to try and use this pointer. So for instance, processing speed, attention, and working memory have a direct effect on work, either directly as well as because they domains like social competence and functional competence. And what we can see from these is that these effects happen independent of the magnitude of positive symptoms or the depressive symptoms that we see, which can also, of course, have an effect on work functioning. Now, one of the questions which has come up often is whether these cognitive problems that occur in different domains are a result of having had the illness for a while, or medication, and so on. And so this is an early study from mid-90s where Sakin and colleagues actually looked at the magnitude of cognitive deficits that are present in a sample of patients who have a diagnosis of schizophrenia but have never taken a neuroleptic. So these are folks in their first episode of their illness. And those are the people in the dotted lines above, and they compared them to a sample of patients with schizophrenia who have been on medications for a while. And the line at the 0 point on top here is what would be considered the average for a control sample of folks without a diagnosis of schizophrenia or any other psychiatric disorder. And what you see is essentially that the pattern of deficits is very similar across both groups. So There are fairly significant impairments across a number of different domains of cognition, which are seen in both groups itself. And the domains of particular weakness seem to be attention, verbal memory, some aspects of executive functioning, particularly abstraction and flexibility, and processing speed. So when we think about what that boils down to, we have a sense here that the poor functional outcome is associated with a number of different impairments in those general domains of neuropsychological functioning. And one of the particular ones that we've looked at is working memory and what are some of the neural networks which are associated with it. So this is a task that was done by our lab a few years ago, and this is a variation of what's called the Sternberg working memory task, and this is an fMRI study. So what happens is that the person in the scanner will see a list of letters, which could be either 2, 4, 6, or 8 letters long, and that varies the amount of load on their working memory. And so they'd be looking at these letters for about 4 seconds. There's a delay, and then they're presented with one of the letters, and they have to say, was this in the string that I saw before? And they say yes or no to that. Now, this data is analyzed using a very interesting multivariate analysis tool that is developed by my colleague Todd Woodward. But what I want you to notice here is that, so this is the brain activity in a sample of controls for a particular component on the left-hand side here, and this is the activity in that same network for patients. Now, you'll notice that as the difficulty level goes up, the brain activity in that network increases. So this is for 2 and 4 letters, this is 6 letters, this is 8 letters in the controls. What you'll notice in the patients is that at 2 and 4 letters, there is an increased activity, and at 6 and 8 letters, the brain activity in that network is almost indistinguishable from each other. So what we're really seeing is that the patients sort of need to generate a higher level of activity in those functional networks to produce performance which is equivalent to the controls. And when those activation limits are reached, then performance deficits start to happen. So we think that essentially it's not that there are differences in the network or that there are some parts of the brain which are not working per se, but that these networks are inefficiently activated. So at those high levels, at those high cognitive loads, you sort of end up with a ceiling effect, and that the performance can't go past that certain point, and then it sort of drops off. And so this inefficient functioning in the network, of course, could have an effect on functioning, as well as potentially the ability to manage some of their symptoms as well. So our hypothesis here is that we've got poor functional outcomes across domains like interpersonal functioning, work, employment, social functioning, and that this is associated with some cognitive impairments, and those cognitive impairments in turn are associated with impairments in functional networks. So this is our model at the level of what is happening as a whole, and it's continue to be seen irrespective of symptomatic state. So they are present even in folks whose some of their positive symptoms kind of have remitted and responded to medication. Some of these deficits continue to be seen. So we want to find ways to sort of improve these outcomes, because this is obviously going to have a big effect on daily life functioning. But typically, of course, when we think about schizophrenia, we're not just thinking about those poor functional outcomes, but we're really thinking about particularly the positive symptoms that people experience. And these symptoms, of course, wax and wane over the course of the illness. During acute episodes of psychosis, they're present, and they respond. They're the symptoms that tend to respond most to psychotropic medication as well. And our hypothesis was that these delusions and hallucinations similarly are associated with biases in information processing, and there are other brain networks which may be associated with some of those biases in information processing that we see. So we've been particularly interested in delusions and looked at a number of different aspects of what may be some of the biases which are associated with delusions themselves. When I was thinking about it, I was thinking, one way for us to conceptualize this is there are these three big questions about delusions that we want to sort of focus on and try to understand, which is how do people develop beliefs or arrive at decisions per se? How do they choose between different alternative explanations that might be present? And of course, when people are experiencing, going through their lives, there is a lot of information that may not fit with their beliefs. But why don't we change our minds in the face of new evidence itself? So I want to go through some of the different studies that we've done that have tried to get at this question. So that first one, how do we arrive at decisions and develop beliefs, is actually kind of a tricky thing to try to understand, because we are interested in the question of how much information are we using to arrive at a decision, but quantifying the amount of information that we use to make a decision is not always an obvious task. So we develop these slightly artificial tasks which allow us to look at decision making under conditions of uncertainty. So this is an example of a task that has been used for a long time, from about the early 90s, and this was a lot of what my PhD research was on. So essentially, people are shown these two jars of beads, and they have beads of two colors in an opposite ratio. So let's say 80-20. So the jar on the left would have 80 white beads and 20 black beads, and the jar on the right would have 80 black beads and 20 white beads. And then the person's shown these two jars, they're put away behind a screen, and they're told, I'm going to sort of open one of these jars and start to take out the beads one by one. I'll show it to you, I'll put it back in, and I want you to tell me, as soon as you're sure, which jar you think I'm drawing the beads out of. So what that allows us to do is, under different conditions of certainty or uncertainty, to look at the amount of information that we use to make a decision itself. And what we found is that across a number of different studies, that people with delusions particularly tend to use less information to make a decision. And somewhere between 30 and 40% of patients with severe delusions will actually make their decision after a single piece of information. So after a single beat, they'll say, I know, and I'm really confident in it as well. Todd Woodward and our team here developed a variation on it. So we call this the fish task. Essentially, there is a fisherman, and you're told that he's fishing out of one of these two lakes. And again, the ratio of the fish in these two lakes can be varied. And then he catches a fish, and you're told, okay, I want you to rate how likely is it that the fish came from lake A, and how likely is it that the fish came from lake B. And you can see that, so the person sort of separately rates it. So in this particular case, because the lake on the left looks like it's got more whitefish, maybe that one's looking more likely, but there's also a small probability that it came out of the lake on the right. And so essentially we can look at the confidence rating that people have for a piece of evidence which matches their hypothesis and a piece of evidence that doesn't match their hypothesis. And what we find is that when we look at the non-matching lake, there's no difference between the groups. So we've run this study a few times, and this is data from an early study done by Will Speechley, and we compared healthy controls to individuals with bipolar disorder and no history of psychosis to people who have a diagnosis of schizophrenia but no delusions, and a sample of folks with strong delusions. And what we find is that the only difference really is that when the color of the fish or the evidence that is presented matches their a priori hypothesis, they become extremely confident in their decision. And that decision can sometimes switch up, but there is this increased confidence. So what we suggest is that even in a neutral context, so what we've done with these different tasks, of course, is not use tasks which are in any way related to their beliefs itself, and it's not particularly emotional. We're really interested in, even in a neutral context, we find that individuals who are prone to delusions, and as well as people who have strong delusions, tend to use less information to arrive at a decision, and that they're more confident in the decision, which is consistent with their initial expectations. And we call this a jumping to conclusions bias, or a hypersalience of evidence hypothesis matches, which is a nerdy term. Now, what we found, of course, is that this tendency to make quick decisions, to jump to conclusions, and this EVH bias that we see has been found to moderate treatment response. So in a study that we did a few years ago, we found that in a sample of people who were just starting to take medication, we gave them these tasks before they had started their treatment. We found that the folks who showed a greater cognitive bias actually had a slightly poorer response to medication over 6 weeks than people who did not show this bias or showed it to a lesser extent. Now, how do we choose between different alternative explanations? One of the things that we know is that all of us tend to prefer self-generated hypotheses. So we developed a variation on that same fish task where you're told, okay, so there's a fish that has come to this lake, and it could have come from any of these 3 lakes, and the person is told, okay, so you see this black fish, which lake do you think that it came out of? And so if it is from that one, how certain are you that it came from there? And the person will make a certainty rating on some trials. In other trials, the computer does exactly the same. So the ratio of the fish in the lake stays the same. The computer says, we think it came out of this lake. How certain are you? So what we essentially have is that the information is matched across those 2 conditions, but in one case, I came up with the explanation myself. In another case, someone else came up with that explanation, and I can look to see the differences in the certainty levels across those 2. And again, what we find is that all of us actually show a bias towards self-generated hypotheses, but that bias is much greater in patients who have delusions, compared even to folks with schizophrenia with no delusions and bipolar controls and healthy non-psychiatric controls. So essentially, we think that because the delusions, the beliefs that people come up with, tend to be self-generated, these may be held with much greater confidence than the things that other people might say to them as alternative explanations. The third question is, of course, why don't we change our minds in the face of new evidence? And this, again, is something that we know for all of us, that the more strongly we hold a belief, the less likely we are to want to challenge it or to be able to give it up in the face of contradictory information. So this is a task that we developed as well, where essentially the person is told, okay, here is a picture of something that's going on, and I want you to rate how likely do you think it is, how likely do you think each of these explanations is. So in this particular case, when you're looking at it, you might think, okay, it's looking like maybe he built a fence for his dog, or he's playing with his neighbor's dog. And then you're going to see something that happened just before that, and so you're going to get new information. And so now it's looking less benign, it's looking less friendly and fun. And then, of course, as you see more information, you get the sense that his neighbor's dog wasn't the charming, cheery character that you saw in the first picture. So these explanations, the 1 and 4, which looked plausible at first go, turn out to be not true as more information comes to light. And so we call those the lures. And then, of course, there are some things which are more likely to be true in this case. So maybe he just escaped from the barking dog. And what we can do is look, as each piece of new information is presented, the person that's doing the task changes their likelihood ratings. How likely do you think that it's explanation number 1, number 2, number 3, and number 4? And they're asked to rate each one independent of the others. And again, what we find is that this is with each new picture that comes up, and you'll see that the other groups, folks without delusions, all those 3 groups reduce their confidence rating to a greater extent than the individuals with delusions. So we call this a bias against disconfirmatory evidence, or BAID. And we suggest that this might be a really important factor in maintaining the delusions itself, because the delusions don't get to be properly disconfirmed because we tend to disregard the information which doesn't fit with our hypothesis itself. And we find that this is particularly seen in people who have severe delusions. much less willing to update their beliefs. And again, what we've seen even with this task is that we've very deliberately used information which is not delusion relevant and not particularly emotionally laden either, so that we're not having the confound of prior beliefs and prior expectations on their decision-making process. So obviously there are a number of factors which are playing into delusion formation and maintenance, some of which we talked about here, but of course there are a number of personalizing factors as well that interact with it, their own histories, their expectations of what's going on, prior memories, trauma, and so on, which will play a huge role in the kinds of beliefs that are developed, and how they hold on to them and why they hold on to them as well. But we're not exploring those at the moment. We're sort of really looking at these general factors here. So in terms of the specific cognitive biases, we see this hypersalience of evidence hypothesis matches, a bias against disconfirmatory evidence, and all of these personalizing factors itself. And we've done a few different studies here and in my lab in Toronto, where we found that there are a number of different networks which are specifically associated with these biases, including some of those limbic striatal circuits in the ventral striatum, as well as more kind of ACC prefrontal circuitry. And we think that a part of what might be happening is that the brain networks respond both to salient and non-salient information, and it biases the way we sort of weigh out information itself. But in the interest of time, we won't go into those right now. But just suffice to say that there are these brain networks. And when we think about treatment, most treatment has just been focused on kind of improving hallucinations and delusions, and it tends to sort of act at the level of the neurotransmitters and the neuroreceptors itself. But we have all of this data now suggesting that there are these difficulties that we're seeing at the level of cognition and cognitive biases. So we've asked the question, is there a way to use this research to help our clients improve their symptoms and daily life functioning? And so cognitive remediation is an approach to improving basic cognitive functioning, and MCT is a CBT-based treatment which is developed by a group which is to improve these cognitive biases itself. And so these hopefully will act at this level of cognition, and we hope that will have a knock-on effect on functional outcomes as well as on symptomatology. So cognitive remediation has been used. It's been used from, I guess, the early 90s onwards, and the group structure that we're talking about is just the one that we are using right now. We're in the midst of a large clinical trial and have clinical groups. And so we run our groups twice a week for an hour. And essentially what we have people do is, this is using a computer program and with the opportunity to practice between sessions as well. And then each session ends with some amount of time to reflect on ways to use these training skills in their day-to-day life. So the computerized software allows training on multiple cognitive domains, and we've been using one which is called SBT Pro, which has been used in other trials as well as in clinical practice. So participants carry out individualized training based on, which are on tablets in our study, but they can do it on any computer and then discuss the real-life applications. And one of the interesting things about this and some of the other softwares that use it is that the difficulty level of the task is adaptive, and it's based on how the person's doing. So if they're doing quite well, the difficulty level increases. If they're not doing quite so well, the difficulty level drops, so that it remains challenging but doable. So these are some of the examples of the types of tasks that are used in the SBT program. So this is a selective attention task where you've got grids of varying sizes, and they're told, okay, as quickly as you can, find the odd one out in this grid, which hopefully most of you saw is that one over there, which is the one which is not filled. And they do this with different types of stimuli, but basically it's just a way to sort of get people to focus on, pay attention to the stimuli that's in front of them, and to shift their attentions away from the things that might be preoccupying them elsewhere. This is an example of a verbal memory task. They're shown a list of words, They have to remember that list of words, and then afterwards they're shown words and told to identify which were the words which are on the list, or sometimes which are the words which are not on that list itself. With varying levels of delay between the time that they are shown and the initial learning list, and they have to go back and remember it. This is an example of one of the executive functioning tasks. This is a computerized version of a task which used to be called the Tower of London task. And essentially, up top here, they're shown the final configuration, and they're told, okay, now I want you to go from this configuration up to this configuration. The only rule is that you can never have a smaller loop under a larger one. So you would have to move, and then they can kind of just drag and drop things on the tablet. So go from there to there, then there to there, and so on. And essentially, they try it out for themselves till they get the final configuration matched to the one in the figure, and they have either done it efficiently or inefficiently. And then if it's an inefficient one, they're told, okay, do you want to try that one again? And once more, the level of complexity adapts to how the person's doing. So cognitive remediation in general is essentially using sort of rote learning or a practice of certain skills with the hope that this is going to improve the underlying ability itself. So, looking at pictures with stars in them may not necessarily improve your attention at work or when you're reading, but the question is, does it generalize? And if so, how much does it generalize? So these are data from a meta-analysis which was done by Susan McGurk a while ago, about, I guess, close to 10 years ago now. And this is not a very readable image, unfortunately, but so if you look at this one, this zero line is a line of no effect. And if the means that we're seeing are on the right side of the line, it means that there is an effect overall. And what you'll see, so the studies have been arranged in terms of the magnitude of the effect, but overall what we find is that we see an effect size of about 0.4. And we see the effects not just on global cognition and on some of those specific domains like attention, processing speed, executive functioning, but interestingly, we also see effects on social cognition, on overall functioning, as well as, interestingly, a smaller effect on symptoms itself. And we're not entirely sure of what may be causing that, but it could be that, again, improvement in basic cognitive functioning allows people to more flexibly consider alternative explanations, hold on to alternative explanations, not get so overwhelmed in stressful situations, and so on. So, the other approach, which has been developed by our group, and a lot of this work has been done by Professor Stefan Moritz in Hamburg, is what we call metacognitive therapy or metacognitive training. And it was originally developed as a knowledge translation tool. So a lot of the folks in our research groups, so Stefan, Todd Woodward, myself, others had been giving these public lectures to talk about, okay, what do we know from the science about these biases which are associated with psychosis. And we got a lot of positive feedback from those early talks. Based on this feedback, we try to sort of develop it into a structured CBT-based clinical intervention. And we call the group training, the group intervention metacognitive training, and the individualized application of it, metacognitive therapy, or MCT+. Now, both MCT and CBT help individuals to understand and explore these cognitive biases and ways of thinking about their beliefs and symptoms. And of course, with CBT, we're sort of getting people to reflect on what are their automatic thoughts or what are their behaviors that are happening in response to it, and get them to identify and reflect on those thoughts itself. And MCT, we're taking a slightly more indirect approach, and we're talking about those cognitive biases that we outlined earlier and saying, these are some of the biases that we know, and could you think about how this may be playing a role? So I'll show you some of the sorts of things that we have. So MCT as well, the way we are running it right now is as bi-weekly, like 2 1-hour sessions, but other studies have done it differently. And essentially there are 8 standard modules and 2 new modules that we've added on. So each of these modules is focused around one of the cognitive biases or one of the processes which the data suggests is associated with delusions. So this ranges from attribution, which is, how do we attribute causes to things like blaming and taking credit for things. Some of the jumping to conclusion stuff that we talked about earlier, the belief change modules are really focused around the bait bias. There is data suggesting that there's sort of poor emotion recognition and slightly poorer theory of mind during episodes of severe paranoia, as well as sort of some types of specific biases in memory and so on. And then we've got a couple of modules which target self-esteem and mood, which we think plays a role in maintaining some of the more negative delusional beliefs. So here are some of the exercises from a couple of the different modules. So this is an exercise from the module 2, and it's really kind of looking at this idea of premature decision making and not updating our beliefs. So people are told you're going to be shown a picture with different explanations, and I want you to think about which one you think it is and discuss your decision. And we sort of have a lively group discussion around it. So when you see this picture, which of those what do you think this might be? Do you think this is a smiling face or a bowl or a boat or a rocking chair or an elephant's head? Then the next piece of information comes in, and so maybe people change their minds and say, oh yeah, maybe this looks like those could be tusks. And as more and more of the picture unfolds, it's starting to look like it is one of them or the other. So in this case, we think it's the rocking chair. And really we're getting people to say, hey, if you'd made that decision early and you'd stuck with it, maybe you wouldn't have got to the right decision at the end. And again, we're using, especially early on in each session, using very non-delusion relevant, non-threatening stimuli, and it's just a game that people can play. I'm getting people to reflect on those underlying processes and saying, could you see how this might relate to sort of what happens in your day-to-day life itself? This is an example from the attribution module. So you're told there's lots of different situations where we try to figure out why something is happening to us. So for instance, you're talking to your friend, you notice that he's not listening to you. What may have caused your friend to not listen to you? Something about me, like, my mind might go directly to I'm boring him or I'm mumbling, or maybe I think it's something about him, he's really impolite, or maybe he's troubled by something, or it could just be that he's distracted by something that was happening outside. Again, what we're getting people to do is to start to consider multiple explanations, to start to think about multi-causal things. It may not just be me, or it may not just be him. It could be lots of different things that are going on concurrently. And we have multiple exercises, and we keep linking it back to the idea that there is data that suggests that some of these things may be worsened in psychosis, or some of these biases. They're all universal. We all do this, but they are worsened either in an episode of psychosis or they worsen in times of stress. So for instance, in this case, when we are paranoid, we tend to blame other people for negative events and failures, or we might think that things are out of our control. And you can see how, if I was starting to see this in general as I'm going through my life, that can lead to interpersonal challenges. So there are multiple modules, and really there are certain kind of underlying themes which keep getting reiterated. So learning to consider multiple explanations, look for beliefs that may help to challenge mine, look for evidence that might help to challenge my belief rather than simply things which reinforce my pre-existing belief, taking our time to make decisions when we're not fully sure about what's going on, or when the decision has sort of important ramifications or consequences. And from the memory module, we get people to recognize that our memories may be imperfect. We fill in the gaps, and sometimes the way that we fill in the gaps may be based on how we're feeling right now rather than what was actually going on. And recognizing that our mood can influence how we tend to interpret situations. So again, that's a sort of CBT-esque idea. And the later modules around stigma, self-esteem are really working on getting to recognize some of those common biases which are associated with sort of low mood as well, and to find ways to work on self-esteem, recognizing our strengths. Because this was also important to us, because there is data suggesting that as people's insight into their symptomatology improves, that is sometimes associated with a reduction, a worsening in mood. So they tend to get more depressed as they recognize the magnitude of some of the difficulties that they've been experiencing. So we did want to not have things be particularly nihilistic or negative, and really sort of say that, this is something that we all experience, and that we need to find ways to sort of challenge these, but also not to sort of blame ourselves entirely for what's happening. So I want to show you just some of the participant responses that we got from it. These are statements that people who'd been through our groups and very kindly shared them with us had made. And you'll see the application of some of these same ideas. I'm walking down the street and I hear a stranger swear. I might have thought that the person's angry at me, but maybe he's just having a bad day, or he's on the cell phone or talking to himself. Just because he said something doesn't mean that it has anything to do with me, or it could be something to do with the situation itself. Or when I saw someone laughing, I used to think that they were laughing at me, but now I realize that I can't jump to conclusions when the person's laughing at me. Sometimes it's amusing when they use our very terms back. But really, we're seeing this idea that, as I'm questioning myself, I recognize my symptoms more readily and see things from different angles rather than my point of view. I really like that phrase. MCT may not cure me, but it's a useful tool. So that's all well and good, where people say nice things to us, but of course, being scientists, we're really interested in the question of whether it's effective or not as well. And there have been a number of small studies which have been run, and a couple of big trials. The biggest one was run by our colleague Stefan Moritz, and this was a 2-center randomized control trial, and we compared MCT and cognitive remediation with about 75 patients in each group. And what we find is that both might improve daily life functioning, but when we look at what is the effect on MCT, so this is just looking pre-treatment, post-treatment after 6 months, and a 3-year follow-up. As expected, the MCT helps to improve delusion, so this is cognitive remediation versus the MCT. It improves delusional, the intensity of the delusions that they experience themselves. It changes the magnitude of some of the cognitive biases. And interestingly for us, we found that over time, it also had an effect on self-esteem. So we've been really interested in this, and we think that the research suggests overall that MCT does improve positive functioning, particularly delusions. It prevents relapse and it improves those cognitive biases. And we've now been interested in doing a study here in Vancouver, because this big trial was run in Germany. And we are in the process of doing, we're midway through a 5-year CISHR funded trial to look at the efficacy of MCT and cognitive remediation on symptoms and cognitive functioning, as well as to try to understand the brain mechanisms which are associated with change. So, we've got data from those different studies suggesting that there are some brain mechanisms which are associated with the biases themselves, and we want to look to see what changes as either cognition improves or functioning improves or the symptoms themselves improve in the same person. So we have people come in, do some of these tests at baseline. They'll get randomized to one of the 2 groups, and then we test them again after they've done 8 weeks of one of the 2 groups itself. And why we find this interesting is we think that they are both going to have an effect on functioning, but through very different mechanisms. So the cognitive remediation, we think, will improve basic cognition, and the MCT will improve the delusional symptomatology. So for those of you who are around the Lower Mainland, the groups at the moment are run out of the Midtown Mental Health team at Ravensong, so fairly close to the Broadway City Hall station at Broadway and Cambie, for people who want to take the subway. And so if you have patients who might be interested in taking part in the research studies, they can contact us at that address. So our lab is called the Cognitive Neuroscience of Schizophrenia Lab, or the CNOS Lab, at ubc.ca. And I want to thank many of my colleagues and collaborators, particularly Todd Woodward and Stefan Moritz, who've really been my mentors for the last 12 to 15 years. Devin Anderson runs the groups for us, and Sarah Flan and the rest of the CNOS Lab itself. And thank you guys for your attention. And I guess we can open it up to questions at this time.
Yeah, so we give folks an opportunity to pose some questions to Dr. Menon, and I just want to say a huge thank you to him for coming and sharing this amazing, really, like, groundbreaking work. I think it's incredibly hope-inspiring to see new takes on some existing challenges, and to do it in a really compassionate, human way. So bringing in the feedback from participants in such a high fidelity manner, I think is really, really in line with what we're hoping to do. So some recovery-based neuroscience research, I think that's fantastic. So I see some folks are typing. I encourage anyone who has any questions. We have a little bit of time, so we can run as long as folks are curious. I'll let some of these come in.
Many people.
Multiple attendees are typing.
Yeah.
Maybe folks are typing their questions in, because everybody's very excited by this. I will pose a question, Dr. Menon, around some of the language used in the presentation in the workshop groups. I saw one of the respondents cite the idea of evidence, and this new idea of, when I look at the evidence, it may not be that that's laughing at me. Was that something that you saw come up, and how was the concept of evidence explored in the group?
So a lot of it is we're getting people to recognize, and this is one of the those CBT ideas sort of brought into the group itself. Sorry if I keep looking off. Matthew's just sitting right there. So it really is about recognizing that there's lots of data from lots and lots of different aspects of psychology that suggest that we have this quick emotional decision-making system and a sort of slower reasoned system. And of course, the more strongly emotional we're feeling, the more we tend to go with that rapid, emotionally based response, and are less able to use evidence for that sort of slower, more reasoned process. So they sometimes call it system 1, system 2. But getting people to even just for themselves, and sometimes be able to say, I know that this is my anxiety talking. I know that this is my paranoia, or I know that I tend to do this, and there have been other times where I've seen that that's not the case. Can sometimes help to sort of slow it down just a little bit. And that's sort of really what it is. We don't think that it's something which is going to change the beliefs overnight, but really to get people to slow it down and say, is there any possibility that there is something else which could be going on, and sort of shake things up a little bit. So it's a very gradual unlearning of a fairly habitual way of responding to situations in stress, and happen sort of piece by piece.
I really appreciate that, and I'm going to let you go. And just because you brought that up, I'm wondering have you looked at any sort of time dose relationship, because it's sort of in part happened over time. It's harder to sort of start second guessing those rote patterns.
Yeah. So the data from the study that we had, which we were really happy with and quite proud of, was the fact that Stefan was able to go back and get the 6-month follow-up data and then the 3-year follow-up data, right? So what we actually find is that with not all of them, but a sizable chunk of the folks who had done the groups, they sort of continue to use those skills and ideas, and over time we see the intensity of the delusions, or the effect that it has, kind of continue to decrease. So it actually drops further from where they were at the end of therapy, and then sort of goes down at 6 months, and then continues for some of them across that 3-year period, and some of them, of course, will relapse. But it was really heartening for us to see that is an ongoing process, and we see the change in the way that we expect it to happen.
So cool. So we can navigate with the scroll bar. In fact, the first question that came in was from Andrian. So that's a little up here. Asking what was the inclusion exclusion.
Oh, so we've tried to keep the groups be as open and inclusive as possible. So there might be people who would be interested in the study and would be willing to do the assessments pre and post. And of course, because that's really more relevant to us and not very helpful to the person itself, we pay people for the time of the assessments itself. It's not a lot. It's about $10 an hour for the assessments, but it ends up, I think, being about $60 each at pre and post. So essentially, we're looking at people who have a schizophrenia spectrum diagnosis, not a significant current drug use. So, this is Vancouver. We recognize that there'll be people smoking weed and that, but just not to the level of dependence, and no significant head injury, which might be sort of impairing cognition in a way that may not benefit as much from remediation or from the groups. Essentially, just looking at people who are interested in the group, able to come in and able to take part in it and can commit to it.
People who have delusions, like have delusions.
Yeah. So and of course, ideally, people who have delusions, but sometimes there are people whose delusions are kind of recovering, or they're not as severe right now, but they've had a strong history of delusions and a diagnosis of schizophrenia, and we've had some of them come in as well because we kind of looking at how people might respond, and we think that it might be helpful with relapse prevention itself. So, if you have people who might be interested, send us an email at that email address, and we're happy to sort of discuss it further. As well as essentially, if there's someone who is really, we'd still sort of try to have them in the group when and for imaging bits, the people who are interested, of course, can't have metal implants in their bodies because they're in the MRI scan.
Angela?
For MCT, is there a minimum requirement of insight specific to the delusion beliefs? Not necessarily, So what we've been thinking is that this is a way to try to get people to reflect on their beliefs, and with MCT, we've tended to take a fairly indirect, fairly non-threatening approach, and we find that sometimes rather than get caught up in whether something is sort of true or not true, we might be sort of willing to get people to say, is there anything else that might be going on? We're not saying, has it ever happened, or is it completely untrue? Just trying to be less confrontational. So, so this goes to so Chloe had asked a question: what is the difference between MCT and CBT, and is there any research that you think that this could be generalized to people with diagnoses other than schizophrenia who have delusions, so like depression and psychotic features? So, yes. We do think that some of these biases are actually transdiagnostically associated with delusion. I know that Stefan has actually developed variations of MCT for depression itself, as well as a version now for BD, looking at some of the biases which are associated with it, and suggesting that it might be helpful across different conditions. So we do think that it is useful for people even who may have depression in the context of depression. And the difference really between MCT and CBT is starting to get people aware in the moment of what their thoughts are. So the approach is really towards trying to identify those negative automatic thoughts, and trying to see the link between the emotion and the negative automatic thought, and then going from the thought to perhaps saying, are there any biases associated with it, or what is the evidence in favor of the thought, and so on. And we've just taken a slightly more indirect approach, where the group sessions are very much focused on the way that belief might play a role in a number of different situations, which have nothing to do with my delusion or my thought or my belief per se. And then the person is invited, sort of subsequent to understanding what is the bias, to reflect on whether that might be playing a role in their thoughts, their day-to-day functioning. So sort of getting at it just from the other way. So CBT goes sort of thought, bias, challenging the thought. We're going bias, thought, updated thought.
More questions coming in. Maybe while we wait for Andrea and Chloe to respond, another question. Anything emerge around participant demographics in particular relationship to the effects of the MCT specifically? I'm thinking perhaps participant age.
We've tried to keep it open, so we've used a fairly broad age range of sort of, we've got like 18 to 65. And, with most, not just with most delusion, but most beliefs, the longer I hold a belief, the less likely I am to give it up and to challenge it, right? So the earlier we can get to it, the more wiggle room and the more flexibility we might have. So, of course, we think that if we can get people in their first episode or as they're developing those delusions, that's really like the best time to be able to do this up, because it's not quite as entrenched, and we don't feel like there's still a little bit of flexibility. It's not so tied into my self-identity, as something. And of course, the more I've held it, the harder it can be to challenge. But on the other hand, sometimes after kind of having had a few years of experience with something, there is a lot of evidence that suggests, okay, maybe that isn't what's going on. People have seen those beliefs wax and wane. So we sort of have pathways that might be able to challenge it, but just in terms of kind of overall quality of life, I believe that the earlier we can get with, the better it would be.
And no different patterns emerging in the data themselves.
No, and so from the previous study data, we haven't really seen any patterns of whether it's more or less effective. But we haven't really looked. We've not had studies which are powered to look at that question. It's still sort of relatively early days with this trial. But
it'll be great to follow. Question from Andrew around group activities, discussions, protocols available for use.
Yes. So sorry. Yeah. The website. So the MCT materials are freely available to download from the website. So if you just put in Metacognitive Training Handbook, or actually there was an earlier slide where I have the link. So it's like uke.de/MKT is the website. But so actually, yeah, that one. So uke.de/MKT. So it's available. It's free to download. It's available in about 30 different languages, and the new modules will, I think, are on right now there as well. Honesty. Yeah, absolutely. So we know, of course, that for many people with schizophrenia, there is a high level of social isolation, poor social networks. There is a lot of data suggesting that, depending on how we've asked the question, anywhere up to 2/3 of the patients would actually meet criteria for or all of the PTSD criteria itself. So these become very, very important things to try to address. Some of them we are able to talk about in groups, some of them we aren't, but that's just because our intervention is really particularly focused on this one. But our hope, of course, is that as people become more engaged with the group and kind of it is a positive social environment, maybe that can lead to sort of increased socialization as well and improvement in social functioning. And we know from the cognitive remediation data that improvements in some of those basic domains of cognition does also lead to improvements in social functioning. But we do want to sort of try to have ways that and encourage people to sort of get out there and use the world around them as a way to sort of both find positive social interactions as well as to challenge some of their negative beliefs itself.
Kudos.
Great, thanks so much, guys.
Awesome. All right. So
thanks again to Dr. Menon for sharing that invaluable knowledge.
So a huge thanks once again to Dr. Menon for sharing that invaluable knowledge and really shedding some light on the foremost edges of fantastic neuroscience research.
We have a question of going forward. We're probably going to be looking at our next sessions, I think, in early fall. Yep. So we'll say thank you to everybody who attended today. We had a fantastic turnout. I really appreciate everybody's interest and dedication to showing. And we will be forwarding more promotional materials in the next little while, come fall, once we have our next sessions booked. So keep your eye out for those. I'm going to close the meeting here so people who have to go can go. But I do just want to say